great. And forgive me if you hear some background noise of some children screaming. Those are my grandchildren that I am supposed to be taking care of today, but actually my wife did the job for me. But they're still screaming in the background. Give me 1 second. Let me see if... Okay, so I'm supposed to, I believe the majority of you are community health workers. Is that correct? Can you just unmute and say yes, or put in the chat? And yes, okay. And okay, a bunch of yeses. If someone's not a community health worker, can you put what your role is in your health system? We have at least 3 community health workers. Okay, I don't see infection prevention. Yes, I saw that at the beginning. I apologize, Randy. I saw that you had put that. Okay. And registered nurse, perfect. So we have nurses, community health representatives, and infection prevention specialists. Good, that's a really good combination for this presentation. So I was asked to talk about syphilis, in how we address syphilis today, and that's what I'm going to do. And the objectives are for you to understand the epidemiology of syphilis in the United States, maybe some more data on Native American communities, and also to understand the disease, that it has different stages, and how do we diagnose it and how do we treat it. I know that many of you are not going to be actually treating it, but it is very important for you to be screening. And many of the screening that we do in the community is through point of care testing. So when you do a point of care test, and I'll show you this later, you find a positive result in 20 minutes or 10 minutes or 30 minutes, depending on the test you're using. So you have the result right then and there, and you're the only one in front of that patient. So it is important to be knowledgeable about the disease so you're able to communicate exactly what does that positive test mean and what they should do, and also to engage them into care, because that is the role of the community health workers, and be able to communicate to the provider what you have found or what needs to be done. So understanding the disease makes it much easier. I do have a lot, I would say it's recent but intense experience working with community health workers, because we set up a program at Cherokee Nation about 1.5 years ago, almost 2. And the combination of having the community health workers with the nurses in the field has been extraordinary. And the job they're doing is wonderful, and it is needed. And it's a job that if someone doesn't do it, nobody will, and you are the one doing it. So congratulations for choosing that, for that service that you provide the community. So let's talk about syphilis a little bit. So what is syphilis? It is a bacterial infection. And here on the left, you'll see like a little corkscrew. That's what the bug actually looks like when you look at under a microscope. It's not easy to see. You have to use very special lights. It's a dark field microscope. And actually, these microscopes are not around anymore. I mean, I'm old enough that I had the pleasure and honor of using one when I was doing my training, but you'll only find these in research labs. But you'll see this little corkscrew thing, swimming around in the lens that you're looking through. It is a bacteria. It's called Treponema pallidum, and sometimes you'll see it as TP as an acronym. And it is transmitted through direct contact with syphilis sores. Now, I could have used sexual transmission, and I didn't use it because although the definition of what is a sexual contact could be pretty broad, you can, as a provider, if you're touching a chancre without a glove that may not be in a genital area, otherwise you would be wearing a glove for sure, you can get infected just by touching that lesion. If you're kissing someone that has an infectious syphilis lesion inside their mouth and you don't see it, and they don't see it, and they don't even feel it, you can get syphilis from a kiss. So it is tied to our sexual behavior in many ways or forms, but it does not mean genital to genital contact. And that's I wanted to clarify that. It is a multi-stage disease, and we'll go over this. It goes through different stages, which has different ways of diagnosing it clinically, and the treatment may vary according to the stage. But the most important thing, it's preventable. And you can not only treat a patient who has the infection, but by treating them, they are not going to transmit the infection to someone else. And that is how you prevent transmission of syphilis from person to the other. And needless to say, our most important target is making sure that pregnant females, they don't acquire syphilis, but if they do have it, that we detect it early enough so we can treat them, cure them, and the Treponema pallidum does not go through the placenta and infect the baby. So we're trying to prevent congenital syphilis. So you can see here in this map on 2013, the number of cases of reported to the CDC of primary and secondary syphilis. And the darker the blue, the more cases. And so you can see in 2013, there were a couple of states that had more cases than others, but overall, the color is pretty light. Now you go to 2022, and it's almost a categorical dark blue across the United States, which means there's a lot of cases being reported. And this is congenital syphilis. So it's not surprising that if you have a lot of syphilis going on in the younger population, especially in females, that you are going to increase your cases of congenital syphilis, because they will get pregnant at some point, some of them. And if they do and they have syphilis, or they acquire syphilis during their pregnancy, they're going to infect their babies. So unfortunately, we have skyrocketing cases of congenital syphilis in the United States. And you can see when we compare 2012 to 2022, there has been a tenfold increase in the number of newborns with syphilis in the United States, for a number of 335 to almost 4,000 cases reported in 2022. That's what's signaling when we have a problem. And why do we that serve Native American communities have a bigger challenge? Is because, unfortunately, the syphilis cases in primary and secondary in the younger population, and also congenital syphilis in the babies, are much higher. They have much higher rates in Native Americans than in other ethnic groups. Now, this is not because of a biological predisposition. We'll see it in the next few slides. This is usually because either many Native Americans do not have access to healthcare, or they do not have some basic social structural needs that have not been met, like housing or water, or things that may put them in harm's way for acquiring, sexually transmitted infections or other infections for that matter, like COVID, influenza, etc. So in Native American populations, there's 3.5 times higher rates of syphilis in general compared to the white population. The Western US seems to be more impacted, but as you can see on the map, it's pretty across the board. If we go to look at specific rates, you'll see maybe in Texas and Oklahoma and those areas, that New Mexico, that the rates are a little bit higher than in California, but in California they're sky high. So it's really not that relevant to this talk. And 30% of the cases are from rural areas, and that's where people have less access to healthcare, and probably where they have less access to treatment. So why are we having this epidemic in the United States? It's not because this is a new bug. Like in 2020, we had COVID. It was a completely new organism. Nobody had encountered it before, and it spread like fire, and everybody got COVID, or mostly everybody got COVID. Syphilis has been around for at least 500 years that we know of, and probably longer. Interestingly, we thought that it started in the Americas and was taken to Europe, but there's pretty good evidence today that actually it started in Europe. Probably it was brought to America by the colonizers. And so the bug is not new. It is sensitive to penicillin. 100% of Treponema pallidum, you can kill them with one shot of penicillin, or 3 shots, depending on your stage. So it's not that now we have a resistant bug that we can't treat. And there's no evidence that the organism, the Treponema pallidum, is more transmissible than it was 100 years ago. So why are we having this outbreak? Well, it is very tied to other epidemics, and it is part of a syndemic, and it's specifically tied to the substance use disorder epidemic. So people who use opioids and other substances have are 3 times more likely to develop an STI, including syphilis, than people who are not using drugs. And the reasons are many, but some are because people, when they are under the influence of a drug, may not be able to take rational decisions like using a condom or having sex with people they have consented with. And that puts them at a higher risk of acquiring a sexually transmitted infection. Now, these are, there are structural, social, and behavioral factors that drive these syndemics. And I'm not going to go over all the details, but for example, if you don't have access to a healthcare facility, which is a structural factor, even if you have syphilis, you may not be able to get it treated. And if you don't treat it, you can pass it along to other partners. And if one of those partners happens to be pregnant or becomes pregnant, then you have a case of congenital syphilis. Then there's stigma around STIs, as there are around HIV and hepatitis and other diseases, which also prevent people from getting good health care. And then there's, social norms, traditions, and shared beliefs that sometimes influence the way that people seek medical care. So the key demographics of syphilis in general, it is more frequent on the men who have sex with men population, but heterosexuals are definitely affected, or else we wouldn't be having cases of congenital syphilis. Some states are more affected than others. I placed there in New Mexico because I actually live in New Mexico. And at one point we were number 2 in the nation on cases of congenital syphilis. And it affects the younger population, usually because it's the one that is more actively engaged in sex and also in having multiple partners. So from 15 to 34 years old, you're at a high risk of acquiring syphilis. But this quote that came from a New York Times article really explains a lot about the spike in congenital syphilis. So I'll read it out, and we can discuss it later if you want to. But when women who are engaging in substance use disorders become pregnant, they frequently avoid prenatal care for fear of being drug tested and potentially losing custody of their child. That means many of them aren't tested for syphilis and don't receive the treatment that would prevent their baby from getting it. And that is very true, at least in my personal experience working in Cherokee Nation. The few cases of congenital syphilis that we've seen have been associated with moms that did not get prenatal care and that were using drugs. And that was the reason that drove them away from prenatal care. So there have been laws that had good intent, but had very dire unintended consequences. And one was forcing providers to test pregnant females for drugs and reporting it to the authorities. And then the legal system, depends on each state, may send social services or child protective services to take those babies away. And that is a disaster. And that has been changed in a lot of Native communities, or it's being changed, but it's still something that we need to work on. So how do you transmit syphilis? How is syphilis spread? So I'll show you some pictures of the source, not that you need to know that, but just to have an idea if you've never seen a case of syphilis. So if you enter in a direct contact with a sore, it's also called a chancre. The chancre has a lot of Treponema pallidum in its surface. It's like an ulcer. And if you touch it and you have a break on your skin, or you're touching it with a mucosa, like, for example, you're having sex or you're kissing someone, then the Treponema pallidum will go into your mucosa and infect you. Usually it's through sexual contact. Like I said, that's the majority of the cases, but also non-sexual contact, but intimate contact with someone with a syphilis sore can infect you. And then mother to child, that's what we're trying to prevent, is the Treponema pallidum can cross the placenta and infect the baby. And depending on the stage of pregnancy, it can have terrible consequences, including the death of the baby or stillbirth, or the baby being born with malformations or with diseases of different organs. Now, people with HIV are at higher risk of acquiring syphilis, but the most important thing is people who acquire syphilis are at very high risk of acquiring HIV. And that is why every time you see someone with syphilis, they should be offered HIV pre-exposure prophylaxis, and also offered, if they meet criteria, and we'll talk about that a little bit later, syphilis post-exposure prophylaxis. These are two pharmacological modalities of preventing HIV and syphilis that have very specific indications, and I'll cover a little bit about DoxyPep at the end. So remember, anybody with any STI, but particularly syphilis or gonorrhea, are at higher risk of acquiring HIV in the near future, and you should focus all your efforts in preventive strategies and education to those patients. So syphilis has several stages, and they're basically labeled primary, secondary, latent, and then tertiary. The ones that you will be encountering most often is probably latent, because when you are screening the community, you're not screening because they have a symptom or a sign of anything. You're screening them because of their age. They're 13 years and older. They should be screened for syphilis. And so a positive test may pop up, and you won't find any of the symptoms of primary or secondary. So latent is, and I'll talk a little bit about this in the next few slides. So primary is when you have the chancre or the ulcer. Secondary is basically when you have the rash. And latent is when you don't have anything except a positive test. So it's called the hidden phase. And tertiary, you probably won't be running into this a lot. This is seen after 10 to 30 years of untreated syphilis. And usually, although syphilis can affect any organ, my experience is that I've seen this a lot in people with dementia. They're being worked up for dementia, and a syphilis test comes back positive. And when you work them up a little bit more, they end up having neurosyphilis or syphilis in their brain. But it's not as common as it was 50 years ago. Because now, why? Because we use a lot of antibiotics now, including beta-lactams, which is penicillin or derivatives, that even if you get treated for, let's say, for example, for a pneumonia with penicillin for 10 days, if you have syphilis, it's going to treat it. So many people get treated for their syphilis, not even knowing they ever had syphilis. Okay, this is a slide that I really like because it puts in perspective the stages. So the exposure means you had an intimate encounter with someone who has syphilis, and you were exposed to the, let's say, the chancre, and so you incubated for 9 days to 90 days. That means the bug is multiplying in your body, but you have no symptoms. It's usually about 21 days, about 3 weeks. And then suddenly, boom, you have a lesion, you have a chancre, and it's usually in the area that you had the contact with that other person. If it was genital to genital sex, it's going to be in your genital area. If it was using your mouth for a sexual encounter, it may be on your mouth. So you have that lesion. It's called the primary lesion or the chancre. And then this is the tricky part about treponema pallidum. It goes away even without treatment. So that's why many people who don't have quick access to a health facility, they may weather that ulcer out for a couple of weeks, and then it's gone, and they say, okay, it's gone. So whatever it was, it's gone. So I don't need to see the provider or the doctor. And then it goes silent for a couple of weeks, and then it comes back usually as a rash. There's other manifestations, but the most common one is a rash. And then again, even without treatment, that rash goes away. And you would be surprised how many times I get called from the emergency room, and they call to, hey, I have a patient with a rash, and I think we gave him antihistamine as it doesn't going away, and this and that. And how old is the patient? It's 30 something. Have you tested them for syphilis? They said, no. Okay, why don't you do that? And then they called me back, the test was positive. So that was a syphilis rash. So it's very easy to confuse with other types of rashes. And then again, it goes silent by itself, even without treatment. Of course, if you treat it, you cure it, and it's gone. But if you don't treat it, it goes silently away, and you enter this latent phase in which there's no signs or symptoms. I mean, your patient's normal. They don't have any, you examine do a full physical exam, you don't find anything. They feel well, but you do a lab test, and lo and behold, the lab tests are positive for syphilis, and they have syphilis. And if this patient never gets treated, never get exposed to antibiotics, they'll develop all these nasty complications at the end, which is, dementia, syphilis affecting your brain and your central nervous system. But I do want to highlight one thing, which is very common nowadays. Early neurosyphilis or early ocular or otic, which is in your ear, syphilis, can happen at any of these stages. So someone can come in with primary syphilis, a chancre, and actually also has ocular syphilis. So that's why it's important. Let's say you're in the field and you're testing, you're screening, right? And the test comes back positive. Then you have to ask more questions like, do you have any ulcers, or have you had any ulcers in your body lately? Have you had a rash that nobody could diagnose? And they say, no, I have not had. How's your vision doing? Oh, it's kind of blurry on one eye. Okay, that's a signal that they need to see an optometrist or an ophthalmologist to make sure it's not syphilis. Or they tell you, okay, suddenly I'm not hearing well on one ear. That's another sign that should prompt a quick encounter with a provider. Or I have a headache that's horrible and hasn't gone away, and I've never had this before. It's not a patient with migraines or anything like that. They should see a provider immediately. That's how you, as a community health worker or infection preventionist or a nurse, when you run into a situation in which a syphilis test is positive, not only ask about chancres or rashes, but ask about vision, about hearing, and about any neurological symptoms like dizziness or headaches or all those things. And I know you're not going to be pulling anybody's pants down in the field and looking at their genitals, but it's important to know what these lesions look like, so you have a better understanding. So these are the chancres. This is in the tongue, this is in the penis, and this is in the labia of a female patient. These are usually sores that are usually painless. They're pretty clean base, like you can see here, and they don't hurt. Now, sometimes they do hurt, and sometimes they're not single; they're multiple. So, the treponema pallidum has not read all the books, and sometimes they do funny things. But like I said, they last for about 3 to 6 weeks, and boom, they're gone by themselves. And the secondary one, the most typical one that we see is the rash, and especially a rash in the palms of your hands and on the soles of your feet. That's very typical. Now you can see it on the trunk also, like this patient. And sometimes patches in your tongue or your mouth or in your anal area or genital area. And of course, don't think that everybody like me that has a little patch on their head has syphilis. This could be just you're losing your hair because you're getting old. But in a young person that suddenly starts losing their hair, that would be something to consider. And then you go into this latent phase. And the latent phase is basically a laboratory diagnosis. I mean, the patient has no symptoms whatsoever, and they only have a positive test in their blood. Now, early syphilis means that you acquired syphilis in the last 12 months. And late syphilis means that you acquired syphilis more than 12 months ago. Latent syphilis. And latent syphilis of unknown origin is that you don't know where you acquire it. So I want to stop sharing a little bit here. I'll continue sharing in a minute. And I want to ask the audience or anybody. Brig cannot answer wherever he is. So how you see a patient, you're in the field, you're testing them, the test comes back positive. What questions do you ask that patient? What would you ask them? The syphilis test is positive, and you were just screening them because it was part of your routine work of screening people for different conditions. Anybody have an idea? And don't be shy and don't be afraid of saying the wrong thing, because there's really no wrong answers. Well, okay, I'll start with one.
If they've ever had syphilis before?
Exact. First, have you ever had syphilis? Because the test that you're doing in the field, and we'll go over that in a minute, it's a treponema pallidum antibody test. And that test, once you have syphilis, is positive forever. So if the patient says, oh yeah, I had syphilis 2 years ago and I got treated, I got a penicillin shot. Okay, bingo. So probably, most likely, they're asymptomatic. That is just telling you that it's a treated syphilis and you don't have to worry about it, and they don't have to worry about it. Okay, say the patient says, no, I've never had syphilis before that I know of. I've never been diagnosed with syphilis. Then what is the next question you would ask them? I'll give you a hint. I'll ask one and then someone else asks the other. Have you had a sore or an ulcer in your mouth or your genital area in the last 12 months? And if they say, yes, I had one and it went away by himself, bingo, that was primary syphilis. And you can say this patient has early latent syphilis because it's been in the last 12 months. Or they tell you, oh yeah, I had one. It was about 2 years ago. Okay, then it's late latent syphilis because it was more than 12 months. Okay, so what you ask them about us? So you ask them if they had syphilis. You ask them about a sore or an ulcer or a chancre. And what other question you would ask them? If they had what in the last 12 months or later?
A rash?
A rash, perfect. Yes, if they had a rash. So if they tell you, yes, I had a rash, and of course that rash was not diagnosed with a specific diagnosis, usually they'll tell you, yeah, it was an allergy to something and it went away by itself. Okay, that's probably syphilis, what they had. So if it was within 12 months, that's early latent. It was more than 12 months ago, it's late latent. And then what else would you ask them? The last things I told you about other complications of syphilis. Is anything wrong with your
vision?
Vision, perfect. With your vision, is anything wrong with your hearing? Any headaches? They say yes to any of those things. The important thing is to refer them immediately either to an eye doctor if it's a vision problem or to their primary care if it's a hearing issue, because then they'll route it to the appropriate specialist. But if they tell you no, I mean, never been treated for syphilis, never had a rash that I can recall, never had a sore, my vision's great, I can see everything, I can hear everything, and I don't have a headache or anything weird, then that's probably a late latent syphilis of unknown duration. And for practical purposes, you treat it the same as late latent. So there's not a big difference there. Okay, great. Thank you. Those are very important questions that most primary care providers miss. So if you can get ahead of the game and do that screening and then communicate that to the provider when you're trying to, engage that patient into care, that would be wonderful. Okay, can you see my slides again?
Yep, you're good.
Okay, thank you. Okay, so just a few words on congenital syphilis. Like I mentioned, if the mom gets infected during pregnancy or had an infection before pregnancy that was not treated, it can transmit the infection to the baby. The moms that have the highest rates of transmitting the infection to the baby are if they have primary or secondary syphilis, meaning they have the sore or they have the rash. That's like 80% chances of infecting the baby. Once you go into latent syphilis, that decreases to about 20% for early latent and maybe 4% for late latent. The problem is that if we don't detect the infection early in the pregnancy, the baby can suffer a lot, inclusive they can die, or they can die, be born prematurely, or have some organ damages. Okay, so what does the Indian Health Service recommend? And I'm using their guidelines because at first I think they are the best and they're the most simple ones. Indian Health Service syphilis screening guidelines is annual syphilis testing for persons ages 13 or older. They may go up to 64, but I just use older just to make it even more simpler. Because you can be 70 years old and still, having sex. And for at least 2 consecutive years or until the outbreak is controlled. So if I start my screening program today, I would screen everybody 13 years older this year, next year, and then I would check, is the syphilis outbreak over? If it's not, then continue checking every year. That's the IHS recommendation. The providers can be assisted with this by using electronic health reminders, showing them, oh, this patient is due for their syphilis test, so they can order it. But if you're screening in the field, you won't have that reminder. So you'll just try to offer the test to everybody who never got the test done in the last year. And also for pregnant females, they need to be screened at 3 points during their pregnancy. First trimester, I'm sorry, week 28 and at delivery. Okay, this is not supposed to go in depth in the laboratory parts, but I do want to give you some hints that I think are important for you to understand what you're doing in the field. The most common and old test for syphilis is called the RPR, and it stands for rapid plasma reaging. And basically, is you grab a blood plasma from the patient and you mix it with a reagent and you spin it in a card like you see here. And if you see like on the right hand upper corner, you don't see anything clumping, that's a negative test. If you see things clumping, that's a positive test. This test is about, believe it or not, 100 years old, and we still use it. So probably one of the best tests in the world, because there's no other test that has lasted 100 years that I'm aware of, or maybe there's a few. And then, so that's the most common test and the one that we were using for a century. We still use it and we still need it, but this is not our first line test anymore. What we're using now is called, we detect treponema pallidum antibodies. And when you're screening in the field, those are the tests that you're going to be using. You're not going to be doing the RPR. You're going to be doing a treponema pallidum test, which is it looks for more specific antibodies against the treponema pallidum. The antibodies on this flocculation test are not 100% specific for the treponema pallidum. They can react on other antigens of the body, and that's why sometimes there's false positive tests with the RPR. If you have lupus, for example, you have a higher rate of having a positive RPR. Even if you're pregnant, that's a risk factor for having not a risk factor, but a factor that may give you a false positive RPR. So RPRs are good. They're lab-based. You do need them for follow-up treatment, but not for diagnosis so much as you use the treponema pallidum test. And the treponema pallidum test, there's tons of them out there. There's not one. RPR, there's only one. But treponema pallidum test, I just gave you a list here of different names that you may encounter in the lab, like FTA. This is fluorescent treponema pallidum antibody. This is TPPA, is a treponema pallidum particle agglutination test. Then you have enzyme immunoassay. So there's a lot of ways that you can detect these antibodies, these treponema pallidum tests. And it depends on your lab which one they have. But that's a lab-based test. The important thing for you to know is that a treponema pallidum test, the one that you're going to be using in the field, once positive, always positive. So the solid line you can see here, patient got infected, the treponema pallidum test went up, and it stays up for life, regardless if the patient got treated or not. The RPR, which is in the dotted lines, when the patient gets treated, it comes down. Usually it comes down and disappears. That's why if you're in the field and you're using the T pallidum antibody, which that's the one you're going to be using, that's why it was important what Jessica asked. Have you had syphilis before? Because if they had syphilis before, that antibody is from that syphilis case. It doesn't mean they couldn't have gotten reinfected. That's a different story. But that means that they probably had this T pallidum test for a long time. So there's several point of care tests for you to use in the field. I'm showing you the two that I have some experience with, but there are others. So the health check is a rapid syphilis test, gives you a 10-minute result. It's like a pregnancy test. You put a drop of blood, you put the solution that comes with the kit, and then you look for a band that tells you that the test is positive. The one that we're using is the ChemBio, and the only reason is because it does HIV and syphilis at the same time. So we are complying with guidelines of screening for HIV, and we also are complying with the guidelines of screening for syphilis. And it's about a 15 to 20-minute test. And it has the other beauty of it, it has a reader. So it's not depending on your interpretation of what you're seeing with your eyes on that band. You know, sometimes bands are light and you're not sure, is this positive or negative? You know, am I pregnant and I'm not pregnant? That's a big question, right? So imagine with syphilis, same deal. But the reader will tell you it's positive or it's negative for HIV and for syphilis. But there's these tests and there's other tests. So you just use the one that is more convenient for you, but just make sure that you read the instructions carefully and you follow the test by the book. So rapid results, that's the beauty of the point of care testing. You get rapid results. You can access more patients than the ones that are not coming to your clinic to get tested. And even if they come to your clinic, many times they won't get tested because the provider forgot to test them or they were in a rush or whatever. But if you're out in the community screening, you have the opportunity to engage with the patients. And believe me, the community health workers that work with our team at Cherokee, they are wonderful. If it was me trying to engage patients in care, I'd be frustrated because I'm not good at that. But they are wonderful, and they engage a lot with the patients, and the patients, they test almost everybody. Now, incentives sometimes are giving for testing, and that helps. Incentives could be in many different ways. It could be gift cards. It could be other, goods that could be food. It could be clothes. It could be transportation cards, etc. Those help you a lot in engaging patients in testing. The beauty about testing, if you find a positive case and you can get them treated on the same day, ideally, it will cut transmission, so that patient will not spread the infection to other patients. And also, giving patients immediate results, it's better. It makes it easier for them to engage in care than doing a send-out test. Like you go to the doctor, they draw the blood, they send it out. God only knows when it comes back. God only knows if they call you to report the results, or if you're there, if your phone's working. And even if all the stars are aligned, then you have to go back to the clinic. And, many people just don't do that. It doesn't happen very often. But when you're in the field and you're telling them this is positive, and you're also telling them, look, it's important to get treated because you'll not infect anybody else. And if you're a female, if you get pregnant, your baby's going to be safer. So you have all these communications that you can deliver to your patient for them to get treated. Like I said, I'm not going to go over the details, but it all depends on which test you are using. Make sure you follow it by the book, because these are CLIA wave tests. And one particularity of CLIA wave tests is that you cannot improvise any part of the test. If they tell you have to use this tube, you have to use that tube. If they tell you have to use this lancet, that's the lancet that you have to use. So make sure you just read the instructions and follow it by the book. And also, have a place that you can record the results of these tests. What we do, since we're screening Native Americans, well, we're screening both natives and non-natives. We open a chart for them. We take a computer, connects to the internet. We open a chart and we plug those results in their chart. So when that patient goes to the clinic, someone can see their test results. If you don't have that capacity, you can always, following your HIPAA rules, print a report with the result, give that patient the result, and tell them, okay, this is the health center you have to go to, or the health department, or wherever you're sending them to get treated. This is the confirmation that your test was positive, just to not lose communication. I know that you don't necessarily do contact tracing, but I just want to give you a very brief overview. In many states, it's the state health department who does it. For tribes who have their own public health department, it would be their public health department. But if there's nobody that's doing it, then that's something you need to solve and see, okay, who's going to do the contact tracing? Because this is critical. So it's basically you identify your partner, you collect information with their permission of partners they may have exposed, in the last few weeks or months, depending on the infectious disease that you're dealing with. And you have to be extremely private in the communications to other people. You won't tell other people, oh yeah, Joe told me that you had sex with him. No, it's you've been exposed to someone who has syphilis or who has gonorrhea or who has chlamydia, whatever. And we're just trying to make sure that you are safe and we can offer you testing and treatment. So everything is very confidential. And also by doing contact tracing, you can test the contact if need be, and also deliver treatment. And this is a very important step in trying to break the cycle of these epidemics. So a few things about treatment. So the main, the recommended treatment for syphilis is benzathine penicillin G, which is a shot. Usually if you have primary, secondary, or early latent syphilis, it's just one shot. And if you have late syphilis, late latent or tertiary syphilis, it's 3 shots separated by a week. There are options for patients who are allergic, and the option is doxycycline, as long as they're not pregnant and as long as they don't have any ocular, neurological, or hearing problems, because that requires a different form of treatment. But if they have a rash or they have a chancre or they're early latent syphilis, a shot of penicillin will take care of it, or 14 days of doxycycline. And then the patients will need follow-up. The majority will need just a follow-up at 6 months and 12 months. If they're HIV positive, it's more frequent. It goes up to 24 months, and you test them every 3 months. And basically, when you're following them, then you use the RPR, because the RPR can give you a quantitative quantitative result. It gives you a titer, so you know they're responding to penicillin, to the treatment that you gave them. But the reality, this is not your job. Your job is to screen them, to inform them, to educate them, and to engage them into care. I'm just giving you this information because the patient will ask you, and how do I treat this? So you can tell, well, it's most likely a shot, but it may be some pills, depending on what the provider decides it's best for you at that moment. And then if they ask you, and that's it, and I'd have to come back, well, you will need some testing done every 6 months for about a year in general, and then you'll be off the hook and you'll be fine. So these are for you to know the answers to questions that patients may ask you in the field. So syphilis prevention, just 2 words on that and I'll be done. So systematic condom use is recommended to prevent, a lot of STIs and also pregnancy. It is a good way to prevent pregnancy if you don't want to get pregnant. But it is, for syphilis, is good, but it's not perfect. Why? Because if you are kissing someone who has the infectious lesion in their mouth, you're not going to wear a condom to kiss someone. And so you're not going to get any protection from a condom in that sense. So that's why it's not perfect for, or if you're having oral sex and even if they're using a condom, depending where the lesion is, you may still get infected. So we do recommend condom use systematically because it does prevent HIV very well. It prevents gonorrhea and chlamydia very well. And it's very good for syphilis, but it's not perfect for syphilis. Avoid combining sex and drugs at the same time. That will decrease your risk of engaging in behaviors that you normally wouldn't if you were not under the influence of drugs. And then we have a new treatment that's fairly new. I mean, it's been here for about 1.5 years or so, which is also to give a pill to someone after a sexual encounter that was not protected. And just 1 pill of doxycycline within 72 hours of the sexual encounter will decrease your risk of syphilis by about 70%, more or less. So, of course, this is not something you will be providing, but it's something that you could be educating on someone who has a positive test, and you can tell them, look, if you want to prevent syphilis, there's a pill that you could do it. Now, right now, the strict recommendations are for men who have sex with men and transgender women, but there's data that's going to be coming out, and if there's a woman that asks you, a female that asks for this treatment, I would not deny it by no means. I would just make sure that they fit the risk profile, and if they are at risk, then I would definitely offer it to them, but it's still not in the guidelines. I just want to clarify that.
Dr. Mera, there's a question about why DoxyPep is not recommended for women.
Okay, so in the medical community, we have, sometimes it's a good habit, sometimes it's a very obsessive habit of only recommending things that have been proven by clinical trials. Meaning, was there a study that looked at people receiving the medication and people receiving placebo, and was there an impact on the medication that the doxycycline decreased syphilis? Well, for men who have sex with men, there's several studies, at least 4 that I can think of. It's probably more. And they all consistently proven that if you take the doxycycline, your risk of syphilis will go down. Simultaneously, there was one study that was done in Africa and in women and did not prove these effects. I mean, giving placebo or giving doxy was the same in reduction of syphilis. But that study had a lot of problems. First, the prevalence of syphilis in that community which was studied was very low. So when you're trying to prove an impact of a medication, if the levels of syphilis are so low, it's going to be very hard to prove the impact. Not impossible, but very hard. And the other thing, when they looked at adherence, meaning that the patients actually take the doxycycline, they found out that the majority of the patients did not take the doxycycline. So you of course, that's also important information that people are not taking it. But it doesn't mean that the drug doesn't work. There have been studies looking at doxycycline levels in vaginal tissue just to see if that was the problem, like it doesn't concentrate well in the vagina, and that's why it doesn't work. But no, they have it has good concentrations in the vagina. So biologically, I think it should work. We just don't have strong clinical trial data yet to say, yes, it does work. And I mean, I haven't reviewed the literature in the last few weeks, so maybe something came up. But we're waiting for a study that says, yes, it works. And when that study appears, then it'll be part of a guideline, because guidelines are not going to put recommendations that are not based on some evidence. But, you know, just to give you an idea, not an idea, a comparison, we started doing universal screening for Hep C 5 years before the guidelines said we should do it, because we thought it made sense. We thought it was feasible. We thought it was not going to harm a lot of people, even if we were wrong. And then 5 years later, it came out on the guidelines, and we screened a bunch of people doing that. And with doxycycline, the other thing I can tell you is it's a safe drug. I mean, I wouldn't use it in pregnancy, but it's a drug that we've been using for 50 years. We know the side effects, and I don't see any major problems causing negative things, and potentially it could be positive. So in summary, if I had a woman who would come and say, I have multiple sexual partners, I'm not going to use condoms systematically, and they already had syphilis or not, but they had other STIs, then I would strongly recommend that. The same way I would recommend HIV PrEP, because the same way they can get syphilis, they can get HIV. I'm sorry for the long answer, but that's the reason. Any other questions? Okay, so overcoming barriers in Native communities. So tribal partnership, more than partnership, I think it's communication and making sure the leaders of the tribe understand what you're doing, and they not only understand, but they support your efforts. That is critical. I am not a Native American myself, but I've been working with Native Americans since 2011. And this is a critical step of making sure that the council members, the chief of the nation, everybody's on board with what you're doing, because your job is going to be much easier, and you will have their support with the community. Do it in a culturally a traditional way, and that depends on the tribe. You know, each one may have their own traditions, and so try to adapt to those and not offend anybody but the way you're doing things. Make sure in tribes that not everybody speaks English, that you have the materials educational materials, and also when you're speaking with them, that you have a native speaker. That's critically important. I have not found that necessity a lot in Cherokee, but I do see it in Navajo, for example. When I work in the hospital, I do run into a lot of patients, especially the elder ones, that do not speak English, and I need the translator, to be with me when I do that. Build trust. That's the most important thing. If the patients trust you, they will accept your recommendations. And that, the reason I think that community health workers are so critical is because they're part of that community. They know the people there, and they have a better access than a provider would, who may not even be part of that community. They're just working there. So I think that's the beauty of having these programs. Syphilis rates are rising dramatically. In New Mexico, in Navajo, they started to come down. That's great news. There's less cases of congenital syphilis reported there in the last 6 months, but they've been doing amazing work to try to curb this. And your role as a community health worker is critical here. And I mean, I'm not saying this just to sugarcoat anybody. Jessica knows me, and I don't sugarcoat anybody except my wife, or I'll get a divorce. And they're critical. I mean, a lot of the screening that we've done would have never happened without you. So, learn more, get educated on the different STIs if you don't know them already, and go out there, screen, and engage people in care. And that's all I have for you.
Wonderful. Thank you, Dr. Mera.